Previously on TB. Last episode, we discussed about the bacteria that is the cause of this tuberculosis infection, who discovered it, and why humans are very susceptible to have an infection from this type of bacteria. If you want to watch this video, you can click on the YouTube annotation or in the link below. Likewise, you can also subscribe to this channel to get more info on the tuberculosis epidemic. Today, we will be discussing on what I want to call as transmission kinetics, or the modes of TB transmission. Because TB is a highly aerobic bacteria, it infects primarily the lungs. However, with the existence of hypervirulent strains, drug-resistant strains, and existence of a wide range of diseases and therapy that can cause immunocompromise or a shutdown of the human immune system, other forms of transmission have been implicated in newer studies. According to genetics, TB started from a mutation of a variant of mycobacteria that is known to infect cows or some other mammalian species in South Africa. When the bacteria mutated to adapt to the human body, it became the various strains of Mycobacterium tuberculosis that we know today. This particular type of transmission is what we call a zoonosis, where a bacteria that normally infects animals actually transfers across the species barrier and infects humans. After the evolution of this mycobacteria, the mode of transmission is now adapted specifically to create a disease in human beings. So the transmission is now from human to human hosts. You see, here in the Philippines, because of poor understanding and the frequent nodding of older physicians, patients tend to believe in a lot of medical myths surrounding TB transmission. One of the most common myths I encounter in my clinical practice is that TB is transferred from the genes. Whenever I take the history, particularly the family or personal and social history, the dialogue usually goes like this. My aunt, uncle, or grandmother or grandfather had TB, so I might have gotten it from them. As I probe further, I then ask the question of how long did this particular relative stayed with you inside your household. They will usually answer me, I never met him or her. They died from TB long before I was born or long before I got TB. If I was a busy physician with a clinic that has a long queue of patients, or if I didn't give a care about what she just said, I may actually propagate the myth by just nodding and taking note of it in my chart, because the patient, which I will not correct, may actually believe that TB is inherited and tell everybody about it. The second myth I encounter here in the Philippines regarding TB transmission is that it is a curse from God, or a punishment for a wrongdoing, or a damnation from a witchcraft. This is a popular notion in rural areas wherein patients live in mountainous areas or in farmlands where TB information is scarce and the supernatural is the best explanation. This has a negative impact on the onset of treatment because they usually present late to the health centers and with complications. Instead of seeking the help of rural health doctors, these patients ask for forgiveness and other supernatural ways to be treated by going to witch doctors or manghihilots. Unfortunately, absolution is a cure for the soul, not for tuberculosis. TB is thus transferred from one human to another human. When we speak, we spread droplets of saliva in the air. When we cough or when we sneeze, a spray of 40,000 droplets gets to be transmitted across the room for about a distance of 2 meters. If that person that speaks, coughs, or sneezes is a patient with an active TB infection, his or her droplet may contain up to 10 tubercle bacilli. And if we ask bacteriologists what is the minimum number of tubercle bacilli to infect one individual, the answer will be 10, or that one droplet. In my previous episodes, I said that TB can survive in a dry environment for about 2 weeks, which means that it can live outside its human host. So in theory, when a patient coughs and the conditions are right and the droplets are suspended in the air, especially in humid climates, that cough or that droplets can infect thousands of people in one sneeze. However, in real life, an active TB patient can only infect 10 to 15 patients in 1 year if left untreated. These are actual transmission statistics done by the World Health Organization. Only those with prolonged, frequent, or close contact with a TB patient have a risk of contracting TB by 22%. So it almost goes without saying that TB transmission is far more complicated than is previously thought. It is actually multifactorial. So TB, to be transmitted, has to rely on bacterial factors, host factors, environmental factors, and factors that affect the person to be infected. I was able to touch on the bacterial factors in the previous episode, so you might want to check that for a review on Mycobacterium tuberculosis. Salient points you can get from that episode include the division rate of the tubercle bacilli, which is 15 to 20 hours compared to other bacteria and viruses, and the presence of strains that are either hypervirulent or hypovirulent. Now for the host factors. Host factors include the bacterial load that is found in the sputum, diabetes or HIV/AIDS, and other conditions that may cause immunocompromise in a host with TB bacilli may produce sputum that have high concentrations of the bacteria. A test called the AFB sputum smear is done free of charge in most government health centers, so we can check if a patient with a presumptive TB case may actually contain TB bacilli in their sputum. Details on how an AFB sputum is done, how it is interpreted in terms of whether it is positive, negative, or how many bacilli are found in each slide will be discussed in a future episode because this is very time consuming. Environmental factors also play a role in how TB is transmitted. Humid environments or windy conditions may make an infectious droplet travel a long distance or can make it more infectious by having it suspended in the air for a very long time. Crowding or crowded environments are the main reasons for most current or modern TB epidemics to occur. Outbreaks have been recorded inside jails, temporary resettlements, especially if populations are moved because of war or disasters, and in shelters wherein patients or group of patients are being kept. Now, before we start with the risk factors for a TB infection, one must understand that anybody can be infected, whatever his body habit is, whatever his health status is. Anybody can be infected, but not everybody develops the disease tuberculosis. The most important risk factor for a TB infection to occur in one exposed individual is if he has prolonged, extended contact or close contact with a patient, especially if it is in a household with a patient with TB disease. This includes caregivers or those persons taking care of a TB patient, which includes also the relatives, the hired caregivers, nurses, and even the doctors who are taking care of a patient. In active TB case finding, the very first persons that are screened are those that are close contacts of a TB patient. Another group of persons who have increased susceptibility of having a TB disease whenever there is an infection include those that have a compromised immune system because of a disease or from medications that they are taking. Tuberculosis is actually an AIDS-defining condition. Whenever an HIV positive individual develops a cough, the caregiver or the provider always thinks that the patient may have contracted tuberculosis. Patients who smoke have a 2 to 3 times risk of contracting tuberculosis from other patients with TB because smoking decreases the number of immune cells found in the lungs. Patients with uncontrolled diabetes have an increased risk of developing infections throughout their body, and especially in the lungs, tuberculosis can easily form. This is because a high glucose or sugar content or concentration in the blood creates or alters the function of immune cells in the body. Now, the following conditions causes immunocompromise by affecting immune cell production. The first one is chronic alcoholism, and the second is immunosuppressive therapy or the use of agents such as prednisone, and also cancer chemotherapy. These modalities affect what we call the hematopoietic stem cells that is supposed to produce new immune cells that is to fight infections such as tuberculosis. There is a question of whether there are other modes of transmission that exist when it comes to tuberculosis. TB doesn't just develop in the lungs. There are a lot of cases of extrapulmonary tuberculosis or TB found in other organs outside of the lungs. The classic explanation for extrapulmonary tuberculosis is that it is TB that starts primarily as a pulmonary focus, wherein the patient gets the infection from other TB patients through airborne transmission. TB bacilli is then transferred to other organs via what we call a hematogenous spread, which means that it travels from the lungs to other organs using the circulatory system or via the blood. When it is seeded in other organs, TB bacilli stays dormant until the time comes when the host loses the ability to control the TB bacilli, and then tuberculosis develops in organs outside of the lungs. However, in practice, I have been able to encounter a lot of cases that cannot be explained by this chart. The following are examples of cases that I have encountered through the years that is not explained by a possible pulmonary focus. Sexual transmission is generally thought as an impossible mode of transmission of TB bacilli. However, in medscape.com, there is a mention of a case wherein a male genital TB patient transferred the bacilli via sex through his partner. There is also a case wherein a Filipino gentleman was diagnosed with brain cancer here in the Philippines and sought help in the United States for a possible operation by a US neurosurgeon. The Filipino gentleman never got the surgery because all of the neurosurgeons he sought consult in declined the surgery because of the location of the tumor. With all of the hope lost, the Filipino gentleman decided to seek consult with another Filipino doctor residing in the United States. And with just a strong index of suspicion and no cranial biopsy done, that Filipino doctor decided to give a trial of anti-tuberculosis drugs that was under the DOTS strategy. The cranial mass that was previously thought of as brain cancer started to disappear. None of the previous doctors ever thought that this could be a TB granuloma because the patient never had any history of exposure to a TB patient and never had TB himself. Another case is a personal case of mine because I was able to handle the last part of his MDR TB treatment. MDR TB is a special strain of TB bacilli which is resistant to two of the primary drugs that is supposed to kill the bacteria. My patient also had no TB and reports to have no exposure to a TB case in the household or anybody at work. However, the patient started to have chronic abdominal pain with development of ascites or fluid in the abdomen. After doing a biopsy of the ascitic fluid, the patient was diagnosed to have tuberculosis. When the sample was cultured, however, the doctors and the patient were surprised to find out that the offending agent is that special type of TB bacilli called multiple drug resistant tuberculosis or MDR TB. Another case is one that I have been able to investigate on, especially since the there was a clustering of cases in one particular household. The index patient in that household is a man who is 40 years old that died of a suspected multiple drug resistant tuberculosis case. The patient was able to infect at least 5 other people in that household with primary tuberculosis and other forms of tuberculosis. But one particular boy happened to have no pulmonary tuberculosis prior to developing chronic diarrhea. The patient was admitted because of complications of dehydration, wherein he developed mental instability. The boy eventually died and was examined post-mortem. There was no primary focus of the tuberculosis, but GI TB was discovered in the remains. When I investigated the case, I was able to find out that the index patient was the boy's father, and that before the index patient died, he frequently shared food and drinks with his son. Since these cases are rare, they are frequently dismissed as impossible, and most of these cases are also not reported in medical literature. TB experts will often cite that a possible pulmonary focus is the primary mode of infection, and this site of primary infection will often heal and give rise to latent tuberculosis on other organs. But with my previous experiences in handling TB cases that I have mentioned before, I'm still open to a possibility that other modes of transmission exist, especially if the TB bacilli becomes more hypervirulent.
And that's all the time we have for today. Thank you for watching On TV. Make sure to subscribe to my channel and follow me on facebook.com/zeromelia and on twitter.com/zeromd. Thank you very much and mabuhay.